welcome to this National MS Education and Awareness Month teleconference hosted by MS Focus, the Multiple Sclerosis Foundation, and made possible with support from EMD Serono, Genentech, Mylan, and Sanofi Genzyme. I'm your host, Casey Minnis, Director of Communications for MS Focus, and I'm joined by two very special guests who I'll tell you a bit more about in just a moment, who will be talking to us about how to become an MS advocate. Now, there are slides accompanying this presentation, and at the end of the presentation, we'll have a brief question and answer discussion. To view the slides and to submit your questions via chat, please connect to the conference online. Go to readytalk.com and join with the access code 7766805. That's readytalk.com, click join, and use the access code 7766805. We encourage you to submit your questions as we go, and we'll answer those questions for you at the end of the talk. Now, let me introduce our speakers. We're very privileged to have two speakers with us tonight. The first will be the Honorable Tony Coelho. Tony Coelho is a lifelong disability advocate. In 1978, he was elected to the U.S. House of Representatives from California's Central Valley, and he was instrumental in the development of the Americans with Disabilities Act. Currently, he is serving as the chairman for the Partnership to Improve Patient Care. We're also joined by Sara Geertruyden, who is the executive director of the Partnership to Improve Patient Care. And in that role, she counsels and manages the organization, which is a diverse group of healthcare organizations representing patients, healthcare providers, researchers, and other groups to promote comparative effectiveness research that supports patient access, informed healthcare decision-making, and continued medical progress. We're delighted that they could be here tonight to discuss this very important topic. And now I will turn it over to them. Thank you both for being with us, and take it away.
Thank you, Deborah. I appreciate very much the opportunity to speak to all of you MS advocates. It's critically important that we in the disability community recognize that we have to be advocates in order to get the things that we need to have done for our community. So having you participate as advocates is wonderful and something that I love you for and appreciate very much your willingness to devote some of your time. This whole effort is a huge opportunity for those of us with disabilities to participate in what I call the disability rights movement. By bringing your voice to the table, by advocating to members of Congress and so forth, you do something that I feel strongly, and it's an ideal that I call nothing about us without us. And it's, I think, critical for us to understand that unless we speak up and speak out, people will do things without us that we may not particularly like, support, or that we can deal with as individuals of the disability community. As some of you may know, I have epilepsy. I've had seizures for the last 60 years, still have them. And so I'm very committed to the disability community out of personal interest. And I have been very active. As Deborah said, I was the original author of the ADA and am involved in the ADA Amendments Act and in a lot of other things dealing with disabilities across the board. I'd like to tell you a little bit about how I got there and a couple of the stories in regards to my involvement. Well, I started having seizures when I was 16 when I had an automobile accident hit my head. And in a central part of California, a small community, dairy farmer, milked cows every morning and night for 7 years, a Portuguese family. And so when the doctors said to my parents that I had epilepsy, they did not accept it because in their culture that if you had epilepsy, it meant that you were possessed by the devil. And so they never told me that I had epilepsy, and so I went to several doctors. They all said the same thing without me hearing it. Then they took me to witch doctors, and that was a very interesting experience. I went to 3 different witch doctors, and of course they didn't drive out these evil spirits. I continued having seizures. And so then I went to college, and after my college career, I decided to go into the priesthood, to become a Jesuit priest. And after my exam, the doctor said to me, "Have you ever heard of the word epilepsy?" And I said, "No." And he says, "Well, you have it. There's some good news and bad news. I can give you medication to help you with some of the seizures, severity of them, and the amount of them, and so forth. And you're 4F, meaning you don't have to serve in the military, which means that this was in 1964, which was right in the midst of Vietnam. And he said, but the bad news is that you can't become a Catholic priest because in 400 A.D., Catholic Church, through canon law, adopted a provision saying if you have epilepsy or possessed by the devil, you can't be a priest." I just want to say right now that I'm still a very devout Catholic, and there's a lot of implications from this. I'll get into a few of them. But when I then called my parents after this, and I said, well, I have some good news. I know what my situation is. I can take medication and eliminate these seizures that I'm having. The doctor said I have epilepsy. And my mother at the time said, no son of ours has epilepsy. And that was the end of our conversation. We did not have a relationship for several decades. I became suicidal because after that, my driver's license was taken away, I lost my insurance. Every time I went to get a job, the word epilepsy was on the job application. I checked it, and I could never even get an interview. And I was student body president, outstanding senior, and I had a lot of people say they were interested in me doing something with them, but none of those worked out. I felt that my church had turned against me, God had turned against me, my family had turned against me, and so I became suicidal. The day I was going to do the dirty deed, I was on a hilltop in Los Angeles, and I all of a sudden I was drunk because I got drunk by 2 o'clock in the afternoon every day, and heard a voice that said, "You're going to be just like those little kids at the bottom of the hill on a merry-go-round, and you're never going to let anything or anybody stop you from doing what you want to do." The result of that, I've never been suicidal again, never been depressed. I still drink, but not as much as I was doing then. But I started believing in myself. I ended up with some good recommendations of ending up working for a congressman from Central California in Washington, D.C., and I worked with him for 14 years, and then when he retired, I took his place. My relationship there is I had a member of Congress who I didn't know all of a sudden became my father, and he supported me when I had a seizure. That was fine. Okay, now it's over. Let's stay doing our job and let's get it done. And I'd never had that feeling before, and it was a wonderful feeling to have somebody believe in you. And all of you, I'm sure a lot of you have gone through some of those same experiences that I did, or have family members or loved ones who did. And so I then, when I was working for this congressman, I would find ways for him to offer amendments dealing with disabilities, but not much was done. Then I got elected in 1978 and decided that I would take care of the needs of my constituency, agriculture and water in Central California, but that on social issues I was going to do my thing, and basically my constituents proved to that. And I got very involved in the whole disability movement, and I'd offer amendments on housing, on transportation, or whatever. And none of that got anywhere because I realized after a period of time that those of us in the disability community did not have our basic civil rights. We could be discriminated against rather easily. If you were in a chair, you could be denied entry into a movie theater because you could be a fire hazard. If you were sight impaired and you went to a restaurant, they could deny you entrance, service and entrance because you were a pain for them, and they have to go through the menu and tell you what's on it, blah, 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 blah. And so if you went to work and you disclosed a disability or had a disability that they could see, they could outright say, because of your disability, I'm not going to hire you. All very legal before 1990. And so I decided to pursue our civil rights, and that's how the the ADA came about. There was a grassroots movement across the country working on this at that time, took advantage of them and so forth, and introduced it. And ever since then, it's been my ministry and my passion to try to make a difference in the lives of those with disabilities. As some of you know, ADA brought about great progress for those of us in the disability community, but not enough. We can do a lot more. We can do better. As you know, 1 in 5 people have a disability. 1 in 10 people have a severe disability. Your employer now cannot ask if you have a disability. Employers, as a result of ADA, now have to provide reasonable accommodations. Yet only 35% of adults with disabilities up to the age of 64 have a job. People with disabilities are more likely to live in poverty as a result of their inability to get a job. But the good news is that bipartisanship has always existed with our movement. The Rehabilitation Act, the Individuals with Disabilities Act, the ADA Amendments Act, were all signed by Republican presidents. And when I started on this effort with the ADA, I wanted to make sure that disability issues were bipartisan, and so that on every legislation I put in, I had a Republican working with me. I was in the House, so I had a member of the Senate working as well, so that nobody could say that our issue was, when we have our disability, it just doesn't happen to those of us who are Democrats or those of us who are Republicans, so that it should be bipartisan. As a Democrat, I always want to make sure that both sides of the aisle are educated on what is needed and what impact it has on those of us with disabilities. Now, we're going through a situation right now where this particular president has been undermining some of these rights that we've developed over the years, but the movement is still bipartisan. It was Papa Bush, as I call him, who signed the ADA. It was his son, W., who signed the ADA Amendments Act. And then you have Senator Bob Dole, who was very active in all we did. So when you go to the Hill, when you talk to members of Congress, remember that our story is a bipartisan story, and we've had bipartisan support over the years. And as I tell groups that are meeting with members of Congress and talking to staff and so forth, don't forget that staff are the ones that report to the congressperson, the senator, what has been going on. So if you meet with a staffer, don't feel slighted. That's the way the work is done. I had a great staff, and they did a lot of the work for me to get me to understand what was going on so I could vote the way that I should vote. But when you go there, it's important that you just don't relate facts. What's very important is that you give some personal history as to why it's important to you as an individual with a disability or a loved one with a disability, whatever it is. But if you need to be emotional, be emotional. Make sure that people understand that this is real, that it impacts you, and they need to understand it. And the one thing to make sure they understand is that our access to care is critical because no patient is average. There's a lot of attempts in the Congress and in the different agencies today to try to put us all in a box and make it average. What happens to me with my seizures is totally different from somebody else has a seizure, or the same thing with MS. All of us are different, and a drug that works for me doesn't work for somebody else. And so it's important that you make that point. And the good news is that, as you all know, there are more treatments for MS today than there were in the past. Same thing with epilepsy. And those are all good, but they're different, and they impact each of us differently. And so you have to be the advocate to make sure that you have the access to the care that is important to you. And the other thing is, and this whole fight on costs in healthcare, don't permit people to put us in the middle. We patients shouldn't be the payers and the government are in this fight is what should be charged and what should be saved and so forth. We're caught in the middle on that, and they try to put us in the line of fire. There's one study that was in the New York magazine, New York Times Sunday magazine, that said by an advocate in this group that if you're 75 and have a disability, you don't have value to society. Well, I'm 76 and a half and have a disability, so I guess I don't have value. I disagree with that, of course. I think I have a lot of value, and so do a lot of you on this call that of same age or getting to be that age and so forth. So don't let people say that if we get to a certain age or because we have a disability that we can't be protective like everybody else. And one size fits all is no solution to any of our problems. And so make sure that as people are talking about cost and cutting costs, they're not doing it on our backs. Making sure that they're actually going right to the part of the issue that where the problem exists. Some of you may have heard of a group called ICER, Institute for Clinical Economic Review. It's the group that basically is saying that we need to do averages, and it depends on your value in regards to that. And ICER is now engaged with several agencies. Sara will tell you more about it later. But we're in a big fight, we with PIPSI, in regards to this issue and taking ICER on, making sure that they don't get so established that those of us with disabilities can't get the medication that helps us or can't get the device that helps us, whatever it is, to give us a better quality of life. And so that's something that we have to fight very aggressively. The other thing, while you're talking to elected officials and so forth, is remember that NIH and ARC are wonderful research institutions, and they've done a tremendous amount of good for the healthcare in our country, including for those of us with disabilities. When Obamacare came into being, not only did it protect those of us with pre-existing conditions, but it also set up a research group like NIH and ARC. By basically the difference is that they're on their board, there are 3 slots for people with disabilities, patients in effect. And those 3 patient spots are there at the table making decisions with NIH and ARC. They listen to us, close the door, and we're outside, and then they make the decisions as to what to research, how to do it, and so forth, without us being involved. And PCORI, Patient-Centered Outcomes Research Institute, but PCORI, it puts us at the decision-making table, and while the decisions are being made, we have 3 people there that can relate to our needs, our concerns, and making sure that we're not overlooked in the process of the decisions. That PCORI will have to be reauthorized, and that will take place, it expires, I think it's next year, so it'll probably be something that has to be adopted this year. So that's going to be an issue that we're working on. PIPSI is working on very hard right now with a lot of the different disability groups. MS is part of that, to make sure that it gets reauthorized and funded, so that the research that is being done with us at the table continues. So it's things like that I think that are important for you to realize what's going on and how you as an advocate can be extremely helpful. I want to finish with a couple of stories so I don't leave you cold on a couple of things. When I was elected, after a few years, I became the majority whip in the House of Representatives. That's the 3rd highest ranking position in the House. And as the whip, I get to make you get to make trips and take a delegation with you, Democrats and Republicans, and you go to different countries on different issues. They asked me where I wanted to go. I wanted to go to Portugal. I'm Portuguese, so I'd go to Portugal and it'd be a state visit and speak to the parliament and so forth and so on. Just the highest ranking Portuguese American in the history of the country. And the State Department then wanted me to go to Morocco because the Portuguese and the Moroccans were working on a Middle East plan, and they wanted me to pass on some information, which I agreed to do. Then I got to pick the 3rd country, and I said I wanted to go to the Vatican and meet with the Pope. So they arranged that, and I took my delegation and met with the Pope, and we had pre-approved, very boring speeches. When the Pope came in, sat down, then I went to the podium and gave my very boring speech. And at the end of it, I said, Your Holiness, I can't live with myself if I didn't say something personal. Now, this is at the Vatican, and the Pope's quarters and so forth. His minions around the room started going, chit-chit-chit-chit-chit, and wondering what the heck I was doing, because that's unheard of. And my delegation, I hadn't told them anything, or my wife or anybody, and they were looking at me as if I were crazy. And I said, I need to tell you something personal. As a young man, I decided I wanted to become a Catholic priest. And upon taking a medical exam, it was determined that I have epilepsy. And canon law established in 400 AD said that if you have epilepsy or possessed by the devil, you can't be a Catholic priest. I think that's very unchristian of our church, I told them, and I wish you'd look into it. That was the end of that. He then gave his very boring pre-approved speech. We took a bunch of pictures and so forth. Then my wife and I walked him out of the room. He was holding her hand, got to the door. He turned around, he blessed her, turned around to me and did not bless me. Any of you who are Catholic know that that's not a good sign. He did not bless me, but he said to me, young man, I heard your comments, and turned around and left. So I thought that I was going straight to hell, that was the end of it. And 2 years later, canon law was changed to permit individuals with epilepsy to become priests. Now, I tell you that story from the point of view of advocacy. I'm not afraid to advocate to presidents, the Pope, or anybody about the needs of those of us in the disability community. And my point to you, all of you, is you can't be afraid either. You've got to be able to try to make a difference, and the only way you can is to advocate. Advocate for your cause. Advocate for the cause of everybody in the MS Society. You've got to be willing to speak out and speak up, and I believe that so very, very firmly. So I just want to thank you for being on the call today, and I appreciate being invited to participate. And I love you for your willingness to be an advocate. So thank you very much. And Sara now will, she's the brains of the two of us, and she will then get into details, and she's the one that makes things happen. So thank you very, very much. Sara?
Yes, thank you, Tony. So, Tony, I think, I thank you for all of your work and advocacy and mentorship. And, I think hearing those stories, it really does make a difference, to understand that we all do have a voice. And, I think you of all people, I think what that story has always conveyed to me is the need to use the bully pulpit when you have an opportunity to speak up and speak out in an environment where amongst people who can make a difference. You have to do that. So thank you. So just as a little bit of background, I'm going to just talk a little bit about who the Partnership to Improve Patient Care is, and who we are and what we advocate for, and then happy to hear from others. So PIPSI is an organization that was established back in 2008, 2009, and originally our coalition was coalesced around the creation of PCORI, the Patient-Centered Outcomes Research Institute. We represent patients, providers, researchers, industry, and we were pushing forward at the time principles of patient-centeredness as the foundation of PCORI's creation. So we really wanted PCORI to have patients at the table, to be independent of government, to have a stakeholder-driven and led research agenda, and for that agenda to really be about clinical effectiveness and looking at, not necessarily one treatment works better than the other treatment on average, but instead, what is it that makes one treatment better for certain people, and what are its impacts on certain outcomes versus another that may work better on other types of people, or people who are seeking other types of outcomes. So it's a much more nuanced mission around personalized and precision medicine. As we have moved forward in that, we identified too that PCORI's creation was really a model for a lot of different things, and the research is only useful if it translates into good shared decision-making tools and improves healthcare decisions. And we really wanted to make sure that patients are at the table, not just in the research, but also in the development of the alternative payment models that are being developed that impact what care choices patients have. And so we've been really also then since then engaging too in these issues around value frameworks, which Tony mentioned, as groups like ICER and others do these types of value frameworks, but in a way that isn't necessarily about individual patient choices. So I'm going to talk about today are threefold. It's PCORI, alternative payment models, and then touch a little bit on the value debate. So we'll start with a discussion about the creation of PCORI. And Tony touched on this a little bit. And I'm going to focus a little bit on PCORI at the beginning because PCORI is up for reauthorization, as Tony mentioned. There were several bills back in the early 2000s, in 2007 in particular, in 2008, looking at comparative effectiveness research. There was an acknowledgement on Capitol Hill that there wasn't enough of that type of research to help people make decisions in healthcare. And so PIPSI was created from that discussion. You may remember that back in 2009, the American Recovery and Reinvestment Act, also known as ARA, provided $1.1 billion for an expansion of comparative effectiveness research. And from that, the Institute of Medicine put together a list of 100 research priorities. But in terms of moving forward the funding to actually conduct those research projects, there were some politics that had to be overcome. So on the far right, there were Republicans who did not think that the government should be funding comparative effectiveness research. They were afraid that those would drive to averages and they were worried that it would also lead to rationing of care when decision makers used that evidence to limit choices as opposed to using that evidence to drive things like shared decision making. On the far left, there was a much different opinion. The far left actually wanted PCORI to be part of government. They wanted it to do cost effectiveness research, cost comparisons, and they wanted it to be used in coverage decisions, the goal being to drive down costs and really sort of, focus what was being covered, particularly in Medicare, to those things that were quote-unquote cost-effective. What ended up happening is that Senator Max Baucus and Kent Conrad, two Democrats, got together with a large number of Republicans to advocate for a patient-centered outcomes research institute that was independent of government and focused on comparative clinical effectiveness research, bringing along a lot of Republican support in the beginning. Some of that support fell away. Well, the support fell away when it was attached to the Affordable Care Act, but I think it's important to note that it was bipartisan in its development. And so some of the key statutory elements were, as I mentioned, the comparative clinical effectiveness research component, not allowing PCORI's research to be used as the sole source of information for a coverage decision in Medicare, making sure it was independent, that there were seats on the board for patients and consumers on the Board of Governors. There's language in there that specifically calls out that the research look at the needs, outcomes, and preferences of patients, and that it looks at subpopulation outcomes, and that there's also support for involved patient and consumer representatives, and they have authority to put together advisory panels, and some of you may be aware that PCORI has an advisory panel specifically on patient engagement. So in terms of moving PCORI forward, it's been since 2010, there's been a lot of work on our part and others to keep PCORI away from the repeal and replace efforts for the Affordable Care Act. We've done that by, keeping in touch consistently with key leaders on Capitol Hill. And thankfully, PCORI is still here, but now it needs to be reauthorized because it's the 10-year authorization originally in the Affordable Care Act expires in 2019 and at the end of the fiscal year of September. And it's also important to note for multiple sclerosis, PCORI has done a tremendous amount of work on MS. They have a multiple sclerosis patient-powered research network. They've had an evidence map that they've developed of all study designs for MS fatigue interventions. And they put $64 million to fund 12 comparative clinical effectiveness research studies related to multiple sclerosis. So in PCORI terms, that's actually a really large amount of money. There are not very many conditions that I think approach that level of funding. And so the messages that we've been delivering to Capitol Hill are that PCORI is supporting improved health decisions. That was its mission. They're looking at subpopulation level information to help with those improved health decisions. Their research is done with a methodology that is credible and reliable. They have an evidence synthesis initiative and dissemination strategies that will ensure that patients and providers can access that information about their treatment options and their value based on personal characteristics, needs, and preferences. PCORI's work is giving us information to incorporate into decision aids, shared decision-making tools, and value assessments. They're really promoting personalized health care, not one-size-fits-all health care, as Tony was talking about earlier. And a key component of that is identifying and measuring outcomes that matter to patients. And it's important to note that a lot of that kind of information they're getting is from requiring researchers to directly engage with patients in those projects. Researchers are required by PCORI to have patients engaged in helping them with that research design. So we look at PCORI as a role model for creating an infrastructure for patient engagement throughout the Department of Health and Human Services. So when you think about CMS and CMMI, the FDA and their patient-focused drug development, and quality measurement, where we look at outcomes that matter to patients and measure success by that. We look at them as a role model for industry in doing their clinical trials, for congressional committees looking for input on policies, and for researchers who are conducting research. But in order for PCORI to get reauthorized is really going to take tremendous engagement from patients. Patients are PCORI's number one constituency. And patients are constituents for every member of Congress. So if you as a patient see PCORI as valuable, policymakers will listen. So I think, from a messaging and advocacy standpoint, it's very important for patients to play a leading role in advocacy for PCORI. It is patients that PCORI is intended to serve. So connecting the dots then from PCORI to alternative payment models, at PIPC, we identified early on as PCORI was getting up and running that they were doing a tremendous job of patient engagement. But then we looked around us and saw CMMI launching alternative payment models and recognized that they didn't have a similar infrastructure for patient engagement. So as PIPC, we've been also advocating very strongly over at CMMI that they establish patient-centeredness criteria. Now, patient-centeredness criteria were actually called for by statute in the statute that creates the Innovation Center at CMS. But CMS has not put together those criteria, so they're not able to benchmark these alternative payment models as to whether they're meeting, whether they're doing that. We've also asked them to put together patient and consumer advisory panels for each of the innovative payment models that they're putting together. And we've asked them to define informed decision-making as a core criteria of patient-centeredness and a goal of each alternative payment model. Shared decision-making is something that is, I think, a big priority for a lot of patients and people with disabilities and providers and consumers. There's actually a playbook that was developed by the National Quality Forum on shared decision-making that is a really great first step that needs to be implemented. And part of, I think, getting to that place where we have informed decision-making, where patients really understand their options, what are my treatment options and how do I make a decision between my options? It really, it is it's important to have that kind of information and tools that are understandable and accessible. So one of the key concerns, though, that we also have about the Innovation Center, and some of you may not recognize, is that the Innovation Center at CMS has authority to do alternative payment models, so to do something different than Medicare's fee-for-service model, where you get the treatment and then Medicare pays for it. Under these alternative payment models, CMMI is given authority to bypass or waive existing Medicare and Medicaid law. So two of the laws that we've expressed to CMMI that we do not want to see them waiving are the prohibition from using the cost per quality adjusted life year to determine effectiveness. And then we also have asked them not to waive it for Medicare, because Medicare is not allowed to use a quality adjusted life year metric in their coverage decisions. And also, if you look back all the way back to 1992, HHS had rejected Oregon's prioritized list of covered services for Medicaid, citing the potential for violating the ADA. And that was also based on the quality adjusted life year. Oregon was using a cost per quality adjusted life year metric to establish their prioritized list as part of their Medicaid waiver. And HHS rejected that waiver and said, no, you have to go back to the drawing board, because when you decide what you're going to cover using that QALY, it ends up being discriminatory. And so keep in mind, in terms of the timing, as Tony said, the ADA passed in 1990, and that came down from HHS in 1992. And so at the core of all of this is, when we think about healthcare value, there's a real drive in the healthcare world to pay for value. And the question that we often come to the table with is value to whom? So if you look at some of the value assessments that are conducted for use by payers, they miss the mark in assessing value to the patient. So groups like the Institute for Clinical Economic Review, ICER, actually rely on this discriminatory quality-adjusted life year metric, which I'll talk a little bit more about. But value to the patient is a personalized, individualized care decision, and we think it should be driven by shared decision-making, quality, evidence-based decision aid, and using PCORI comparative clinical effectiveness research as a component to make better decisions. So why do we talk so much about the QALY? The QALY is a measure developed by researchers to compare the benefits of treatments for cost-effectiveness analyses. But increasingly, these assessments are being relied on by insurance companies to determine whether or not patients can access treatment. It is a singular metric that summarizes the outcomes and benefits experienced by patients, regardless of preferences and perspectives, into a single number. So when Tony talks about one-size-fits-all, QALYs are sort of a way of creating this average metric, but it doesn't necessarily reflect people who don't fall in the average. So if you think about a QALY, the way that QALYs are measured, a number one is a year in perfect health, a 0 is death, and anywhere in between there fall real people. And so if you look at this chart, what a QALY will measure is the cost per the incremental improvement in quality of life. So if you're in the middle and you have a wheelchair, and that's who you are, that's where you're going to be, your maximum potential in terms of quote unquote quality of life might be a 0.5. So if you're sick and you go down to a 0.3 and you find a treatment that will get you back to a 0.5, your 0.3 to 0.5 is only a 0.2, right? So that incremental improvement in quality of life seems small. Whereas if you're somebody who can get to that one, perfect health, or what we would define as perfect health, or what Iserwitz or somebody like that would define as perfect health, right? If you went from a 0.3 to a 1, that's 0.7, and that looks like a better incremental improvement in quality of life. And so the cost, from a cost perspective, the cost per QALY would be better for somebody who can achieve what we would call perfect health. So in that way, this metric ends up discriminating because it looks at somebody who may have a chronic disease or a disability, who perceives their quality of life as a 1 or even better. But on these arbitrary sort of charts, they look like they have a lower quality of life. And so what happens is that we're ignoring differences in patient needs and preferences because they're based on averages. And we know, as Tony mentioned, that different people respond differently to the same drugs. And we know that for many conditions, such disparities are reflected in clinical knowledge, but not yet in the research literature. And so there are a lot of limitations from QALY-based cost-effectiveness analysis. They're acknowledged by experts to discriminate against people with disabilities by placing that lower value on their lives. They tend to devalue the full range of benefits and costs that matter to patients through simplified disability weight systems. They ignore important variability in patients' individual needs and preferences because they're developed using population averages. So what does this mean? If you look over the last few years, or last couple of years, and I just looked at the budget again today, the President's budget continues to propose a 5-state demonstration that invites states to, quote unquote, make coverage decisions that meet state needs. You see a lot of states following suit to propose policies that rely on the cost per quality adjusted life year to limit formularies. Some of you may be aware that Massachusetts had applied for a Medicaid waiver that was denied. But in the denial, there was, and this is a quote, adopting a closed formulary with at least a single drug per therapeutic class would enable MassHealth to negotiate more favorable rebate agreements with manufacturers. The majority of commercial pharmacy benefit managers have adopted such closed formularies, which allow them to customize their drug offerings based on clinical efficacy and cost considerations. So what that means is that CMS is opening the door to states doing limited formularies using these kinds of cost-effectiveness studies. We're seeing that already, and I'll talk about that on the next slide. And the Innovation Center for Medicare and Medicaid, as I mentioned before, is able to waive some of these laws that would normally ban use of QALYs But now they're introducing ideas such as the International Pricing Index. Internationally, those kinds of coverage decisions tend to be made based on QALY-based cost assessments. On Part B, we're seeing more and more activity around step therapy, which also often looks at these kinds of QALY-based studies. But as I mentioned before, QALYs have historically been rejected by policymakers. So there are provisions in law that would normally preclude the use of QALYs in our government programs. And this is just a quote from the HHS Secretary back in 1992, opining on how use of the quality-adjusted life year is discriminatory. So in terms of latest developments in the states, just to put this on people's radars, in New York, there was recently legislation allowing for use of value assessment to determine supplemental rebates, allowing for drugs with multiple in a class to be excluded from formularies. Currently, something that we've been very focused on, the legislature is debating their budget, and in that budget is some explicit authority that would codify their ability to use a third party like ICER to determine these target prices. What's concerning about that is where you have multiple drugs in a class, states could potentially exclude some drugs and include others. In Massachusetts, there also was initially a reference to value in their policies. There are disability groups in Massachusetts that are actively opposing and calling for a ban on the use of QALYs as part of the Massachusetts proposal. And we are hearing that other states, too, are considering these types of policies. So I often say to advocates, when you see buzzwords like value, cost effectiveness, third parties, based on evidence-based research, the question you just need to ask is who's making that decision, and how is that decision being made, and what is the implication of that decision? What are policymakers able to do in terms of limiting access as a result of those kinds of studies? And so this slide articulates what would happen if QALYs were the basis for Medicare coverage in Part B. And I would point out to you on the second bar with MS drugs in particular that a lot of these, this was say 93% of those drugs could be forced to alternative treatment if the QALY were the basis for which Medicare Part B covered care or covered treatment. And we see this in other countries that rely on the quality-adjusted life year. They tend to have worse outcomes, particularly when you look at cancers. Fewer options. If you look at some of the newer cancer medications, you see access restrictions, slower access. This is based on cancer, but we're seeing similar news internationally around access to and coverage of MS drugs, cystic fibrosis drugs, et cetera. And so just to end, in terms of next steps, some of the things that we've really been, that we're advocating for and hope others will advocate for as well is really supporting the PCORI reauthorization and their continued development of comparative clinical effectiveness research. There's always this chance that some will try to advocate for PCORI again to do cost effectiveness. We would consider that to be a potential poison pill for that piece of legislation because there's a lot of opposition to PCORI doing average cost effectiveness and a lot of support for it doing more clinical effectiveness where people can understand the nuances of what treatment works best for which patient and when. And it's important, I think, as advocates to educate other fellow advocates on these very, very, very complex issues. Oftentimes when I talk about quality-adjusted life years, people kind of glaze over. It's a very complicated, difficult issue. This metric is complicated, and I think, but it's important for people to understand why they need to understand it and why they need to pay attention. And like I said earlier, question payers when they claim that they're basing coverage on value. And to tell state policymakers that as advocates we oppose the use of cost-effectiveness thresholds as the basis for Medicaid coverage policies and tell federal policymakers similarly that we don't want them waiving these policies through their innovation program. And then opposing from an employer, insurer, and PBM standpoint also advocating against that kind of discrimination. We had a very positive outcome. We've had a positive outcome with one PBM that threatened to use a cost per quality adjusted life year metric to determine their formulary. And once it was explained to them the discriminatory implications of that, they backed off and are continuing to have conversations with us about alternatives. So it can be done. And we're out there kind of pounding the pavement on these issues and are happy to provide support for any other advocates that want to do the same. So that's all I've got for today. I'm happy to take questions if anybody has questions about what we've gone over.
All right. Thank you so much. Let me just remind our listeners, if you have a question, you connect online through readytalk.com, click Join Meeting, and use access code 7766805 to submit your question. Use the online chat button. For those of you who are online, if you have questions, please submit them now. While we wait and see if there are any questions, let me just ask, in regards to supporting the PCORI reauthorization, what do you recommend that our listeners do to show their support?
So I think reaching out to House members and senators is first and foremost. Right now, the lay of the land for PCORI reauthorization is that Senators Cassidy, Capito, Van Hollen, and Warner are taking the lead over in the Senate. They're in the process now of meeting with stakeholders to try to put together a reauthorization bill. We're expecting similar activity very soon on the House side with Congresswoman DeGette taking the lead. But we do expect it to be bipartisan on the House side as well. But what really resonates with members is it's not just sort of the standard PCORI talking points, which, I mean, it's great. But to the extent that anyone has an experience participating in a PCORI-funded project or can talk about the PCORI-funded projects and the hope that it involves for them and what it could mean for them in terms of the kinds of healthcare decisions that you're making, we're finding that those personal stories really resonate very well up on Capitol Hill. Helping members of Congress understand what makes PCORI different. And there is a new umbrella group called Friends of PCORI Reauthorization that is focusing on a lot of these issues. We expect to have a website up very soon, and I would absolutely hope that we could get that out to everybody who's on this call once we have our new website. And there will be advocacy materials available on that website that help advocates know how to engage, some templates, sort of, if you want to write a letter, we're going to have a template for people to write a letter and personalize it, that kind of thing.
All right, and the foundation will certainly help get that information distributed. We have a question from Lester. He says, my view has showed most payers, private and governmental, use cost savings analysis to decide formulary and class of reimbursement. What payers can be utilized as a role model for the adoption of QALY criteria?
It's a very good question. So I don't know that I have necessarily an answer to who is a role model. I will say that we have had a positive experience with, as I mentioned, one particular PBM that proposed to use a QALY-based threshold that backed off of it, and I think because they were listening. And now I think generally speaking, payers are using these kinds of cost-effectiveness studies in formulary development, but some more than others. And I don't have a good answer for who the role model is in that regard. It's a very good question. But I will say that I do think that there are some payers who are relying less on ICER style studies and starting to rely more on clinical effectiveness studies when they think about formulary development as a result of a lot of advocacy.
Okay, and our next question is, what is a good way to keep on top of these issues as they arise?
So you can always check into the Partnership to Improve Patient Care's website. We're at pipcpatients.org. We have been, this is what we do. Our focus as a coalition, so we're not a disease-specific organization. We're kind of at the 30,000-foot level. But what we do is we're monitoring everything that's happening with PCORI. We're monitoring what's happening over at the Innovation Center in terms of alternative payment models. And we're looking very closely at how research, cost-effectiveness style research is being potentially used to limit access. And we're now starting to focus on that more and more in the states, where we're seeing more state-based activity than we had in the past. So if you're in tune with our website, and you're getting our updates on Mondays, and and we have a place where you can sign up for those updates that we send out every Monday. That will certainly, that's the first step to staying plugged in, because we try very hard to make sure that we're sending those updates on a weekly basis.
All right. Well, thank you very much. I see that we are just about out of time. So I'd like to remind our listeners, if they missed any part of this teleconference, it will be replayed on msfocusradio.org and available on demand. You can follow MS Focus on Facebook, Twitter, and Instagrams for times and access information. Our teleconference series continues on March 21st when Ann Pietrangelo discusses Living with MS, 5 Steps Toward Empowerment. We hope that all of you will join us then. Our sincere thanks to our sponsors for their support of National MS Education Awareness Month, to all of our callers for your participation and questions, and especially to the Honorable Tony Coelho and Sara van Geertruyden. Thank you so much for the time you spent to prepare this detailed information and share this important information with us.
Well, thanks to everybody. This was really it was an honor and a privilege to do this. And as you heard from Tony, he really is the superstar in all of this, and is a great mentor. And and if you ever want to reach Tony, feel free to reach out to me directly, and I can make that connection, because he likes to connect with people personally.
He was certainly an inspiration. Well, thank you so much. We appreciate it. And to everyone who joined us, thank you and good night.